There's just my title slide where I work locally at La Maestra, FQHC in City Heights. I teach at UCSD's pharmacy school. I also teaching at Loma Linda and University of Nevada, Las Vegas, and have clinics throughout Northern California and Southern California where I'm seeing patients, about 200 patients a month. I'm following 5 Wilson disease patients now actively, and inside the groups that I have association with, it's probably about twice that number. I've been very interested in Wilson disease dating back to the beginning of my career. When I was in San Francisco at California Pacific Medical Center, we transplanted a number of children and adults. I think the number was in the 50 range by the time I left San Francisco, who had Wilson disease, and saw many form fruits of this disease state. And we're going to get into that. I'm going to move relatively fast, and I'm going to try to speak to the patients, the support, and the sophisticated people on the line. We have Dr. Schwartz, a wonderful pediatric hepatologist here in San Diego, Dr. Balistreri, who's an internationally known leader who is also president of the ASLD, a pediatric hepatologist here. So hopefully we'll have time for comments. I will try to finish punctually in about 40 to 45 minutes. So we have 15 minutes for Q&A. I know Scott already has some Q&A that's already teed up. This is a live webinar. It's being recorded. The slides are available for share through Scott or through my website. So lots to do here. This is a disclosure, and I do have a consulting relationship with Orphalan. I'll get into what I use and why I think through things, and we'll be talking about treatment shortly. So we're going to talk about the basis of Wilson's disease, including pathophysiology. How do you make the diagnosis? Where are the challenges? How can you effectively treat and monitor Wilson disease patients? This is sort of like hepatitis C. You treat everybody. And the question is, how do you scale treatment? How do you decide on your different treatment options? This was first described by Dr. Wilson in 1912. He eventually, with the collaboration of many other people over time, determined this as a genetic disorder, autosomal recessive. So you basically need 2 genes. This is the ATP7B. It is a copper transporting gene / protein. And we have genetic tests that look for both pathologic and non-pathologic variants. I think there's about 1,000 variants out there. About 400 have been linked to Wilson's disease in a pathologic sense. This can affect children and adults. It typically presents early, but I will give you a very short case of a 56-year-old woman who was in one of my clinics in the Bay Area, who had been diagnosed 10 years ago with fatty liver disease. She was a little bit overweight, had a few minor signs of metabolic syndrome, but something was a little atypical about her fatty liver. So her local gastroenterologist sent her to me. I said, oh, we need to work up Wilson's disease, even though this individual's 56 years of age. And indeed, she had on liver biopsy far above 1,500 micrograms per gram of copper, and had very high urine copper excretion, and did have some subtle neurologic changes that in retrospect were probably not so subtle, but we got to be sensitive. And basically the message here is the age range for Wilson disease, my ceiling is typically around 65, but there have been case reports up in the 70 range. So there's very different levels of penetrance of how this disease can present, including acute liver failure or severe neurologic disability or progression to cirrhosis and liver failure or acute on chronic liver failure. And of course, transplant and death are serious late complications. So 1 in 30,000 people, I think this number is a underestimate. I think the number now that we've got all these genetic sequencing and better profiling, but it is a rare disease. And I'm going to make an estimate. It's probably 1 in 20,000 people. So a little bit lower or a little bit more common than what this is denoting. 2 to 3,000 cases have been diagnosed in the US, and we are on the hunt because this individual waited 8 years from the onset of her atypical liver disease before her Wilson's disease diagnosis was established. I have a very low threshold for checking ceruloplasmin, very low threshold, even if ceruloplasmin is normal, to get a 24-hour urine copper. I have a low threshold to proceed to a liver biopsy. I was just sent a case from China with slightly elevated liver enzymes, no neurologic signs, but there is something atypical about the laboratory profile. I just felt that there is a concern here. Went straight to genetic sequencing before a liver biopsy and had two different variants for Wilson disease. So this is what we call a compound heterozygote. That patient is now on their way to getting a liver biopsy. And Michael Shilsky, who's one of my mentors, sent me an email today, which I haven't read, but I'll find out his opinion because I do like to run all of my Wilson patients through one of my mentors, Valentina Medicis at UC Davis. I do want to give a shout out to the Wilson Disease Association and their meeting about 4 weeks ago on a Saturday, all day on a Saturday in Sacramento, co-supported by UC Davis and Valentina and her clinical leadership and also her basic science skills that she has. So we have resources on the West Coast, we have resources on the East Coast. We have our pediatric resources. If I've got an atypical case, I do call Kathy Schwartz for help in different areas of genetic diseases that can manifest as adults. Copper is essential for a variety of critical metabolic functions, and their gut is absorbing copper and transported to the liver. It's loaded or carried in this protein called ceruloplasmin that we use to measure to screen for this disease. And because of this transport protein, this ATP protein we talked about, copper moves from the liver into the bile. But if you don't have enough of this transport protein, copper gets retained in the liver, gets spilled over into blood, and then copper goes at various places in the body. And we're going to talk about those various places in just a moment. Here's a little diagram about this ATP transmembrane transporter that uses energy. It's one of the reasons I think it's called an ATP. And copper excretion in the bile is highlighted here in this cartoon, and also copper spilling over into the blood, which can bind to ceruloplasmin or albumin or other proteins and can partially neutralize. But if you have this flood of copper, copper starts going everywhere in the body. And the key places where copper has major effects, of course, we talked about the brain and neurologic presentation. In a country like China, where most of the liver disease is being managed by infectious disease doctors, Wilson's disease had a later presentation with severe neurologic defects. And the great majority of the Wilson's disease in China is managed by neurologists. For some reason, it's maybe a genetic or a phenotype where it's got more neurology than liver presentation. But copper can hurt the kidneys. It's not just the liver and brain, and we'll talk about some other organs in a moment. And it can cause in the kidney a flaw in managing acid-base balance and can result in something called RTA, renal tubular acidosis. So when I see a Wilson patient I'm working up or following, I look at the chemistry panel and I monitor the bicarb. The bicarb is something in the blood that signals an acid-base balance or imbalance. So a lot of detail on this slide. Again, the slides are for share, and you can look at this later. I'm not going to read through this slide. It could take me a half an hour to talk about everything here. Brain, liver, joints, just like iron overload, it can cause an arthritis picture. It goes into the eye and something called Descemet's membrane. The copper builds up there, and the ophthalmologist can help us diagnose that with a new optical, I think it's called tomography. It's which is better than looking at it with a slit lamp that we might look at with a normal flashlight. It can affect the heart, just like iron, and cause a cardiomyopathy, a dysfunction of the heart. And I mentioned the kidneys, and it can really change red cells and platelets, not just by causing cirrhosis, but it can cause bone marrow disturbances. So we can sometimes pick that up. And now what's also not on this slide is the presentation with acute liver failure. And these patients can have super high bilirubins, but normal alkaline phosphatase. Usually when the bilirubin's high, it's called cholestasis. It builds up these toxins in the liver and in the blood, and the alkaline phosphatase goes through the roof. We don't understand why this happens, but it's a classic test that we would have on our boards where a patient could present with acute liver failure and hemolysis. The red cells are breaking and dumping what's called hemoglobin into the bloodstream and can really make people quite yellow and jaundiced. So, what would raise your suspicion for a Wilson disease patients? Tremor and depression, but normal liver tests? Maybe. But let's say they had normal blood tests, liver tests, but someone said, oh, the ultrasound shows a little fatty liver, because Wilson disease can present with fatty liver, but atypical, something where fatty liver patients usually don't have significant psychiatrics or trouble with tremors at an early time point in their life, or movements that could be like an early Parkinson's. Elevated liver enzymes, but no neurologic symptoms. I'm still going to think about Wilson disease. I'm going to look at the alkaline phosphatase and GGT, look at the enzyme pattern, look for signs of hemolysis, look for signs where the kidneys might not be working correctly with an imbalance of acid and base. Psychiatric symptoms. Well, we need to be thinking about any patient with a psychiatric disorder with liver disease, fatty liver disease, atypical liver enzyme pattern, very low threshold. The ceruloplasmin test probably costs $7. So it's not expensive. The urine copper test might be $40 or $50. So it's easy to do inexpensive tests before jumping into a liver biopsy, which is a little bit more expensive. So here, the main answer here is mood changes or tremor with elevated liver enzymes and a family history of liver disease. I ask every patient, is there some liver problem that runs in the family? Very important as a screening test. You can pick up different things. So I think we've covered everything on this slide. Yes, this is just a nice summary here. And you'll see on all these slides, there's no S on Wilson's disease. I love having debates with some of my colleagues about whether it should have an S like Wilson's disease. But the correct terminology we changed a number of years ago to drop the S, so it's not like Wilson possesses the disease. So Wilson disease, in my opinion, is a little bit more proper. We talked about acute liver failure. There's a lot of data on this slide. One thing I don't do on my patients where I'm working this up is checking the serum copper. At this time, that's not, in my opinion, a useful test. But there are new tests coming, including tests that Orphalan's helping to develop about non-ceruloplasmin bound copper, free copper that comes up with a more accurate assessment. So the other thing I don't do is stain the liver biopsy for copper. I send the liver tissue to a special lab and they measure the amount of copper in the liver tissue in the liver biopsy itself. And you don't need much liver tissue for this assessment. The labs do a fantastic job. And that is the ultimate way to make the diagnosis, just like with hemochromatosis, too much iron. It's not the genetic test. It's not the lab tests. It's the biopsy, or with hemochromatosis, now we're doing magnetic resonance scans. In the Wilson world, we're still doing biopsies. Maybe we'll come up with a better scan in the future to avoid biopsies. This is a list of different types of neurologic symptoms where people can't speak correctly. They have an abnormal tone in their muscles, in their body, a tremor at an earlier time that might look like Parkinson's disease, but the person's 26 or 32. Movement disorders where they can't walk correctly. Their face has changed. Their movements are slow. They're rigid in one arm or one leg. I've seen all these different presentations. One case that I saw early in my career was a Vietnamese man in his mid-30s who had been in a psychiatric ward for 3 years with catatonic depression. So he was basically not able to move anything, and they were feeding him with feeding tubes. And there were comments in his chart that, oh, it must be alcohol, or it must be burned out hepatitis B. And this is all, I'm going to say, an ethnic misdirection because it was a Vietnamese man. And he saw three psychiatrists who were administering electroconvulsive therapy for his depression, and he had Wilson disease. And he was transferred to Cal Pacific when I was there with acute on chronic liver failure and diabetic ketoacidosis, because copper can go into the pancreas and cause diabetes also. So he ended up getting a transplant. He got a lot better, but he never fully recovered. He could not go back to work as an auto mechanic. And he eventually developed kidney failure from the copper overload historically, even though we put in the liver and he was decoppered. You want to do genetic treatment, just put in a new liver because you're replacing all of the defective proteins and the genes that are in the liver, or at least expressed in the liver. Now, what about doing an MRI scan, not of the liver, but of the brain? So I have a definite protocol now, which I've been taught by Dr. Medici and Dr. Shilsky and Peter Ferenczi, who's now passed away, who was also one of my mentors in Vienna, Austria, is that you do an MR scan and you look for different types of copper overload in the basal ganglia, a special part of the brain. But I am looking at Wilson disease screening up into age 65 with ease, with a very low threshold, and maybe older if something really fits. So now you got a 32-year-old. Which of these is going to be your strongest inclination or hint this person may have Wilson disease? And here we have progressive tremor, progressive trouble speaking, depression, but normal liver enzymes. But I will bet that this person on an ultrasound had fatty liver, because most of these patients do have some type of fat dysmetabolism. So psychiatric symptoms we've gone through, it can even present with psychosis or a schizophrenia-like syndrome. There could be major mood disorders, aggressive behavior, but the psychiatric disturbances aren't always dominant, aren't always present. So they can present with a liver manifestation or psychiatric manifestations. Those are the two domains that we really think about with these patients, although there are other effects. Which of these would be the most suspicious for Wilson disease? 16-year-old with panic attacks, 22-year-old with what's called bradykinesia with elevated liver tests, 28-year-old dystonia, but now hallucinations and elevated liver enzymes. I don't like this LFT thing, but it's for another time. Or recurrent migraines and depression. So what are we going to be thinking about here? New onset. But I would say B, I'm going to be thinking about Wilson disease as well. So there's really two, in my opinion, correct answers on this slide. This is a picture of an eyeball with these brown rings, a brown ring around the cornea. You can see that very clearly because this person has blue eyes, but if they have brown or dark eyes, more difficult. Call in your eye doctor, your ophthalmologist. And this follows what's going on in the brain. If you've got copper here, it's usually copper going into the brain as well. It says slit lamp here, but we have something better than slip lamp now with this new type of tomography. You can have weird eye movements. You can have these special sunflower cataracts, which are in the back part of the eye, and people can have trouble opening their eyelid in a command fashion. So we have AASLD, really nice guidance for diagnosis. Of course, you're going to take a family history. You've already taken a personal history. You don't have to have KF rings, but a low ceruloplasmin is going to trigger you to think about this. But 5 to 10% of people with Wilson's disease have a normal ceruloplasmin. So really the best two screening tests is a ceruloplasmin and a 24-hour urine copper collection. Of course, you're going to go through their liver tests, their liver enzymes, their bilirubin. You're going to do a neurologic assessment, and if you need help, of course, get a neurologist involved. This non-ceruloplasmin-bound copper, NCC, I'm going to say hold your breath. That hopefully will come in the next year or so. Very low threshold for genetic testing, but the genetic testing doesn't make the diagnosis. It's the liver biopsy with liver copper quantification that wraps up that diagnosis. So you put the whole package together, and that's what we do in our hepatology world, and our gastrohepatologists that are out there are helping us screen for this with the low threshold. We do want primary care providers to be thinking about this. I love it when they come in to see me and the ceruloplasmin and 24-hour urine copper has already been done. And you can see on the left side of this graph a summary of what we've talked about. There's something called the Leipzig scoring system. So it's nice to have this on paper. When you think somebody has Wilson disease, you can run through this score. It helps you. But I really want to have that liver copper. But what if the liver copper is in a indeterminate zone? It's not over the 250 magic number. It's 150 or 125. Healthy person should have less than 25 or 35 at this, what are called micrograms per gram in their liver. But if they get into that gray zone, then it really is important to do this Leipzig scoring system and do the chromosomal testing, because the mutations help you a lot. You can see here, like this person who was presented to me from Beijing yesterday had 2 chromosomal mutations. They were 2 different ones. So that's, again, this fancy medical term called compound heterozygotes, and definitely had liver disease, had fatty liver disease, and we're going to do more for that workup. So lab values in combination are most consistent. Well, I've given you some answers, but elevated ceruloplasmin, throw out A. Normal ceruloplasmin and normal liver tests, probably throw out B. C jumps out at us, low ceruloplasmin, elevated 24-hour urine copper. So really, these are our 2 partners, our 2 pairs for that screening process. Emerging tests, we talked about this new test, the non-ceruloplasmin bound copper, and I'm saying it's new. It's been around for a while. I've only ordered it once, and I don't think I really got the right answer back on it. It didn't fit the rest of the clinical scenario. This relative exchangeable copper hopefully is coming down also. That's something we can do through our reference labs. The ATP7B peptide analysis with newborn screening is emerging. Dr. Hahn in Seattle has been at the forefront of pediatric newborn screening for a variety of genetic diseases, and Wilson's disease is now part of that screening process in the state of Washington. This may eventually go national with the help of many of our other genetic metabolic experts, because there's lots of other genes out there. Just in the liver world, we have a panel for cholestatic liver disease that I'm checking in adults. I've used it in 70 adults so far, but it's a very useful test. Looks for 143 different genes that are associated with different types of liver disease. So we're getting to, as these tests get cheaper and cheaper, to start diagnosing these much earlier. So you don't have to wait to do a clinical manifestation profile where other things keep messing things up, like someone's drinking alcohol. Well, is the alcohol causing the liver disease? Or is it Wilson disease? Or is it another genetic disease? So there's a lot more coming here, but genetic testing is widely available. The insurance companies, of course, balk at paying for it because it's about $1,000. But the new test that just came out from Prevention Genetics has a Wilson disease genetic screening variant inside that test. It's a special type of genetic sequences that's a subtype of what's called whole exome sequencing. So challenges we talked about: inaccurate, late, gray zone, too old. I went to a board review course earlier this year for Wilson's disease. Well, for genetic liver disease, somebody was speaking and said, no, after 45, you don't have to screen for Wilson disease. I sent them a message. I said, wrong. Even 65 may not be the right ceiling. 72% of patients with Wilson's disease are misdiagnosed. And here's a long list of different things that are going on. And this leads to a late diagnosis. So often they present with neurologic and cirrhosis. So we really need to be teaching our psychologists, especially our psychiatrists, to order these 2 simple, inexpensive tests. This is definitely on their board exam. If you're a neurologist, you do psychiatric training, and I guarantee you it's on their boards. But then They might forget about it for 10 or 15 years until something jumps up and sort of hits them in the head. This just goes back to other interesting observations in patients with acute, what's called fulminant Wilson's disease. The AST to ALT ratio can be high. This is part of the liver panel that's there. Total bilirubin, but low or low normal alkaline phosphatase. I've seen that in multiple Wilson patients. High bili, low alkaline phosphatase, and would love to have somebody explain it to me why that occurs. But these are just little hints. Ultimately, liver tissue, 24-hour urine copper, Leipzig score, genetic testing. So it's a little bit complicated. Referral triggers, I think we've discussed everything on here. This is just a nice summary slide. Yeah, it's just a nice way to kind of pull things together. Let's move to treatment. We're about halfway through or 3/4 of the way through our presentation, so this is important. Low copper diet. There is a fantastic cookbook just released by the Wilson's Disease Association 4 weeks ago at the meeting in Sacramento. How to cook with a low copper diet. I have one sitting up with my cookbooks now in my kitchen, just a few feet away from where I'm sitting right now. Pharmacotherapy, chelation. We want to bind that copper, get it out of the body, and we want to block copper absorption if that's the direction we want to go with management or a mixture. And of course, transplant. We're trying to avoid transplant. It is a form of gene therapy, of course, to replace the whole liver. And then you want to treat neurologic symptoms, psychiatric symptoms, and partner with a psychiatrist, partner with a neurologist. Super, super important. There are a few foods with high copper. Nuts. Oh my gosh, that's terrible. Chocolate, which I personally can't eat, but shellfish, soy-based products. I didn't realize that till recently. I knew about mushrooms, and of course, organ meats are high in copper, especially if you're eating pate or some type of fried liver. But don't get too compulsive because we have these chelating agents, and some of us use zinc for managing Wilson's disease as well, because zinc does a lot of interesting things in the intestinal tract to block absorption or have something called metallothionein, which has sulfur groups that bind copper in the intestinal tract, decreasing copper exposure to the liver and to the body. So one thing I don't use is D-penicillamine, although that is still available. I think it has too many side effects. It can have some liver toxicity. It can have kidney toxicity. It can have bone marrow toxicity. It can cause a lupus-like reaction. It's different types of rashes, GI upset. I've really switched to using trientine, and there's two choices on here. Trientine with 2 hydrochlorides on it, or trientine with 4 hydrochlorides. And it's that trientine with 4 hydrochlorides, which is the most recent innovation in managing Wilson's disease. And that's what Orphalan makes. It's FDA approved in the US. It's FDA approved and available in China, different countries in Europe, South America, I think in Brazil. So that is nice too, because it doesn't require cold storage. That's very important when people are traveling. Like my patient who I just diagnosed in San Jose this last year travels all the time, and she has to keep her trientine 2 hydrochlorides, the or earlier available substance, in a cooler. She has to carry a cooler around whether she's traveling around the United States. Zinc has been available, and there is a prescription level, pharmaceutical level zinc called Galzin that's available in the US. And that, as I mentioned, induces what's called metallothionein, a protection substance in the intestinal tract and other places, but in the intestinal tract specifically, and helps block intestinal absorption. That's for maintenance. You can use trientine for intolerance of penicillamine, but I go directly to trientine in my practice. I don't go through the penicillamine steps because I can always find a reason not to use penicillamine. So this is a nice summary, and by applying these medicines early and effectively and combining that with diet, you can really save people's lives. You can prevent transplant. You can reverse neurologic conditions. I've seen some amazing events. So this is a nice summary about zinc. Now, my challenges with zinc is I've had a couple zinc failures who were switched to zinc and went into liver failure, probably because they weren't fully decoppered. And then I saw them when they were developing liver failure. Also, zinc needs to be taken multiple times a day, and you can't take zinc with your trientine or penicillamine if you use it, because penicillamine and trientine will bind the zinc. So it becomes quite complicated where you're taking your trientine twice a day and you're taking your zinc 3 times a day. Now you got to take something 5 times a day. And patients have trouble taking anything more than once a day. Twice a day is sort of the challenge. So, but there are people that use zinc alone. There are people that use trientine, decopper, then switch to zinc. There are people in this area that use a chelator plus zinc in this combination therapy. I'm giving you my algorithm here, but there are multiple choices. And in this world, you could say, well, everybody's right, provided that the patient's taking all of their medicines correctly. So we do want to keep things simple. You know, with hepatitis C, we just treat everybody. HIV, we treat everybody. Well, with Wilson's disease, we treat everybody, but you want to keep it simple to keep your patient compliant. And I've seen some major complications of non-compliance with progressive neurologic in young adults. This just talks about how trientine works. It doesn't just bind copper and help with copper excretion, but it also blocks intestinal uptake like zinc. So if you are taking trientine, do you really need zinc? And I'm doing some projects with Wilson experts around the world to try to tease out what is the most effective and what leads to the highest compliance rate and what leads to the best copper protection that's out there. So this is a very nice metabolic study showing that trientine in the right tube little boxes, blue is good and orange and yellow and red is bad. Trientine in this study worked much better than D-penicillamine. This is the work by a very famous, I call it, I don't know, molecular diagnostician in Denmark. He's done a really fantastic job with this. Okay, we talked about all these medications. I'm just working through. It's just a lot here. Lists a lot of different side effects can be there. You can have side effects from trientine. You can get rashes from that. There's can be GI upset also. But this trientine dihydrochloride needs to be refrigerated at all times, or it loses potency very quickly. The 4-hydrochloride, which is called Cuvrior, that's the brand name, does not require refrigeration. And maybe someday we'll get a dosing of this that can be given just once a day, but that's a project that's in development. So we have a 22-year-old person, fatigue, high liver enzymes, neurologic symptoms, tremor, slow coordination. We've proven Wilson disease with the low ceruloplasmin, elevated urine copper. An MRI shows T2 hyperintensities. This person also should have, well, it's not in this case, have had a liver biopsy to quantitate the copper. No significant medication history or allergies. What's the right thing to do? This is a new diagnosis. So I'll give you some hints here. You're not going to start with zinc therapy. Zinc is not for newly diagnosed individuals, in my opinion. Though trientine and penicillamine are your two options, there are a lot of us who start low and go slow with these medications to make sure they don't have significant adverse events and that the copper mobilization is slow, because sometimes patients can have worsening of their neurologic symptoms because of too rapid copper mobilization. So I still even say that some people think that penicillamine is an option here. I'm biased against penicillamine, but I'm telling you what's in the guidelines and what some specialists do around the world. Okay, now we've got a person who's on penicillamine, which I wouldn't use, 2 years ago, hepatic and mild neurologic symptoms, new onset joint pain, rash, and worsening tremor with bone marrow suppression, no white count, and now spilling protein into the urine. As I mentioned, there are risks with penicillamine of being nephrotoxic. She's been adherent. So are we going to continue penicillamine? Probably not. Are you going to switch to zinc monotherapy? Probably not, unless you've got good evidence this person is fully decoppered. Transition to low dose and dose escalation trientine. Are you going to stop therapy and watch copper levels? Probably not. So the right answer here is to switch to trientine with this dose escalation. You want to build a good patient relationship. There's a lot of different processes here, but these people need active interaction, active follow-up, definitely referral to neurology, psychiatry, psychologist if you need to work with appointment reminders. This disease, people do get lazy after a while. They're decoppered, they feel good, their neurologic symptoms are gone or markedly improved. Then they start forgetting to take their medicine. And if they're on and off these medicines, they can get flares of disease and can decompensate. And if they're not fully decoppered and you switch to zinc monotherapy, I've had multiple cases of rapidly accelerating liver disease. What's the most common reason for non-adherence, non-compliance? Low dose schedule or high dose schedule? Intravenous administration. Now, letter B on here is a little bit of a red herring we're throwing in here, but in China, they have copper chelating agents that are given intravenously in the neurology clinics because they're inexpensive. They've been used for decades. In my opinion, the data is very thin to think about this, and that's why patients really need to be on frontline chelating agents as we have described. Complex dosing regimens. We know if you go from once a day to twice a day to 3 times a day to 5 times a day, adherence and compliance drops precipitously, especially in adolescents and young adults who've got a busy life and they can't be thinking about carrying a box around and do to take your medicine every 3 hours, whether it's chelation or zinc and alternating. So, of course, complexity is always a challenge. There are issues too with food restrictions and timing with food that make things a little bit more difficult with our chelation agents and more importantly with zinc. So the future, let's get to a wrap up here, Scott. We're almost at the 6:15 time point for Q&A. A lot of things are in development. Most importantly is gene therapy. So lots going on with delivering ways to modify, uh, insert a functional gene. And those, there is one study that is ongoing at this time, and I believe there's another one that's planned. The very bottom says prime editing, and that's a new way of correcting the mutations and editing at the DNA level. So we have gene therapy with what are called CRISPR. We have another technology that's from algae called ARCUS, and they have what are called mega nucleases that can also do work in this genetic domain. So lots going on for the future of Wilson's disease. Fortunately, we have patients that are investing their bodies and their time. We have investors and pharmaceutical companies that are developing new treatments, also new tests. I mentioned Orphalan's developing a new copper test that may be better than our current dependence on 24-hour urine copper. So I would like to have a blood-based test if I can. So